It's a pleasure to talk to you through today on the basic concept through clinical examples. Okay, here's my conflict of interest. So I'm going to start with a slide listing 3 myths or truth. The first scenario is when you see an abnormal macular OCT scan of a patient with suspected inherited retinal disease and there's no peripheral changes, you must be dealing with a macular dystrophy and not a cone or cone rod dystrophy. Is it myth or truth? The second scenario is when you see a patient with a normal ultraviolet field autofluorescence imaging and a normal macular OCT in an asymptomatic patient. You can be reassured that this patient does not have any retinal or macular disease. So a situation like this, somebody who comes in with a cataract, and you think, okay, the retina looks normal on all multimodal imaging. Therefore, this could be a good candidate for multifocal IOL implants if they want to be spectacle-free. Is it truth or myth? Lastly, only ERG recordings done in a dedicated electrophysiology laboratory in a tertiary center can be useful in clinical assessment. True or myth? So with the first question, I'm going to give you a few examples. These are OCT scans through the macula, and some of them showed very subtle changes in the ellipsoid zone. For example, these, I'm going to use a marker. Don't know if you can see my cursor, but on the left-hand side, there's a gap or optical gap. On the right-hand side, these 3 OCT shows attenuation or abnormality in the ellipsoid zone. And down the bottom right, there's a gap there as well. So are these macular dystrophies? So LA30 or the light adapted 30 Hertz flicker looks something like this. But if you actually see that kind of tracing, you'd be pressing the arrest bell. This is ventricular tachycardia. So ventricular tachycardia, as you know, is a life-threatening condition. Now, we're not dealing with that, but the waveform can be quite similar. So this is what a waveform of light adapted 30 Hertz looks like. There's peaks every 30. It's at a rate of 30 Hertz based on the stimulation rate. And the parameters that we extract from this are the 2 things. One is the peak amplitude and the peak time. And there's a range that we look at, see whether that's within the normal range. The LA3, here's Quentin playing the game here. So LA3 consists of A and B wave. This originates from the cone photoreceptors as well as a bit of bipolar cell and the bipolar cells. So from this testing, the single flash or 2 Hertz flash, we can tell whether the abnormality is located in the photoreceptor or post-photoreceptor level. And so there are parameters that we can look at, for example, A wave and B wave amplitude and peak time. So both of these tests are useful in looking at cone pathway abnormalities. The LA30 gives us an indication of whether there's global cone abnormality, and LA3 to localize where the abnormality is, whether it's at the photoreceptor level or post-photoreceptor. So here are the results. First case, basically flat 30 Hertz flicker. So here we know there's actually a problem with the cones, even though the abnormality is localized in the fovea. So it's not just the problem here. The normal retinal areas of retina that looks normal is actually abnormal functionally. Similarly, in the second case, all very abnormal cones. However, the first 2 does not have an S-cone response, whereas the third one has an S-cone response. So the third case affects the median long wavelength cones preferentially. The next few cases have reduced or delayed cone response, but it's not abolished or eradicated. And in the third case, the dark adapted response was supranormal as well. It's taken from another paper. So I just want to draw your attention to this recently published review article looking at phototransduction proteins. And in that, it shows the phototransduction cascade. And all of these proteins outlined here can be involved in various forms of cone or macular dystrophies. So we know there's opsons that are involved in capturing the light. And at the end of the chain, the channel has to be closed or open based on the concentration of cyclic GMP. And diseases affect these proteins CNGA3, CNGB3, as well as opsin genes can cause cone abnormality. So the first three examples were achromatopsia for both top and middle. And the last one is blue cone monochromacy, where the abnormality is in the loss of long and medium wavelength opsin gene. Now, it's important to know that when we see a flat 30 Hertz flicker, we need to consider whether there's preserved S-cone. There's a few conditions where S-cone can be preserved despite a flat 30 Hertz flicker. And these are the conditions listed here. So in blue cone monochromacy, we know the short wavelength cones are not affected. GNAT2, that's transducin protein that causes achromatopsia, can also have preserved S-cone. And PDE6C and PDE6H, which are phosphodiesterase proteins, can also have preserved S-cone. So the fact that we can see preserved S-cone can point us towards these genes in a patient with cone abnormality. The other cone abnormalities that we need to know are guanylate cyclase and the GC-actin protein, so GUCY-A1A, GUCY-Y2D, as well as the voltage-gated potassium channel. So these are examples of cone dystrophy. The top one's due to GUCY-A1A, GUCY-1A, and the second one is GUCY-2D. So these are the most common dominant cone dystrophies. And the last, KCNV2, causes cone dystrophy with supranormal rod, ERG, is uncommon. This is a rare recessive condition. Finally, there are also conditions that affect the fovea and does not affect cone function. So we need to keep in mind an optical gap doesn't always equate to achromatopsia or cone dystrophies. It could be ABCA4 or macular dystrophy due to Stargardt's disease, as well as RP1L1, which is occult macular dystrophy. PRPH2 can cause central areolar choroidal dystrophy in the third example here, which may only have macular dysfunction with a normal cone function. CDHR1 can be very mild. PROM1 also similarly can just affect the macula without significant cone abnormality. And the last example is surprising, but it's becoming more recognized, is that Bardet-Biedl syndrome 1, BBS1, disease can give you an isolated macular dystrophy. We used to think that this is the disease that causes systemic disease as well as cone rod or rod cone dystrophy, but it's possible that BBS1 variant in homozygous state or compound heterozygous state can give you a pure macular dystrophy. So what happens if the retinal imaging looks normal? But is it? So here is 4 examples I'm going to give you. First is a 30-year-old man who wants clearance to work in the police force. His retina looks pretty good on autofluorescence imaging as well as the OCT. Another patient, 57-year-old geriatrician, who wants to discuss cataract surgery. He's got a bit of myopia, but apart from myopic changes, there isn't really anything significant. Then there's a 55-year-old male lawyer who has unilateral vision loss. He's been complaining about this washed out color vision perception for many years. And lastly, a 52-year-old female who had LASIK 5 years ago, but noticed declining vision in the left eye, just the left eye. You can see some changes in the left eye, but is the right eye normal? So I'm going to introduce the concept of DA 0.01. So this is a dim flash in the dark adaptive state. So after 20 minutes of dark adaptation, only the rod photoreceptors are working, and they then transmit a signal to the on bipolar cells. So we see a signal here from the on bipolar cell. We don't see the A wave, it's too small here. So it's a scotopic 0.01. It's generated by the rods, but the response we see is from the bipolar cell. Next is the DA3. So this is a standard flash, still in the dark adaptive position. So you can see the waveform here of the economy following financial crisis, which looks like DA3. There's an A and there's a B wave. The A wave originated from the rod photoreceptors, whilst the B wave comes from the bipolar cells. And the ratio between the B to A wave should be greater than 1.2. Anything less than that will be reduced. Anything less than 1 will be electronegative. So here we have the 30-year-old man who wants police clearance clearance to work in the police force. He's 6'12" in both eyes. He's got normal looking OCT. But his ERG is not normal. So you can see the dark adapted DA 0.01. There's a delayed B wave and reduced. And it's electronegative. You see the A wave is good, but the B wave severely reduced. And we use the red eval in the clinic to confirm these findings. You can see that there is not just the reduced B to A ratio, there's a Bifford profile in the light adapted 30 Hertz flicker. So in fact, the light adapted responses here gave us a diagnosis. Whereas the dark adapted responses tell us this is electronegative, but actually doesn't tell us which type of disease it is. So it's more useful to do the dark light adapted, plus the on and off responses were attenuated. So this condition is incomplete CSMB, just based on our testing in the clinic, which takes about 5 to 10 minutes without dark adaptation. This is a 57-year-old geriatrician who wants to discuss cataract surgery. And an important part of that discussion is actually what lens to put in. He's myopic. You can see here the choroid is very thin. So we did the ERG in the clinic, which took 5 to 10 minutes. And it shows that he's got a broadened A wave in the light adapted single flash response and a sharply rising B wave in the 30 Hertz flicker. So we have not put in through 20 minutes of dark adaptation to get a dark adapted response. This is all light adapted response. And we can see that on the on and off response, he's got loss of the on response, but preservation of the off response. Based on this pattern, we've got a diagnosis for him without putting him through dark adaptation or even waiting 6 months for the testing. So the diagnosis here is that despite normal looking retina, apart from the myopic change, he's got complete CSMB, even though he's asymptomatic. But after further questioning, he says he did have difficulty seeing in the dark for many years. This is a lawyer who's 55 with unilateral washed out color. And OCT looks pretty good in both eyes. There's no thinning of the nerve fiber layer, no thinning of the outer nuclear layer. But on dark adapted testing, you can see that it's almost flat in the right. On the left, there's a reduced and delayed B wave. And in both eyes, there's a mild reduction in the A wave, suggesting some photoreceptor abnormality, but more importantly, there's loss of the B wave. So both eyes have reduced B to A ratio, and in the right particularly, it's electronegative. This is despite healthy looking retina. So his symptom is only in the left eye. However, the electrophysiological abnormalities is in both eyes. Lastly, this case had LASIK 5 years ago, ended up losing vision in the left eye following LASIK. So here we can see in the dark adapted response that there is severe attenuation of the B wave. However, if you look closely in the right eye, which she's asymptomatic in fact, she may even be considered having, needing surgery soon for her cataract. The right eye, in fact, has reduced A wave. Now, you wouldn't have, you never guessed that looking at the OCT or the autofluorescence that she's got a reduced A wave. So there is photoreceptor abnormality, rod photoreceptor abnormality. The left eye is severely abnormal. And if you look at the single flash light adapted response, there's also abnormality in the A wave. So that's the normal looking eye, in fact, abnormal. The left eye is obviously abnormal with almost undetectable 30 Hertz flicker. Now we did her ERG, red eval, because I want to use this device to monitor her right eye. And I can see that her 30 Hertz flicker amplitude is already reduced in the right eye. It's undetectable in the left. So I can use this quite quickly and easily at every visit, every 6 months or every year, depending on the symptoms, to see whether there's progression in her right eye. Make sure she does not develop the same problem. We presume this is an immunological process affecting both eyes, but asymmetrically and symptomatically only in the left. Now, finally, the last myth is that ERG has to be done in a specialized laboratory to be clinically useful. We have, over the last 10 to 11 weeks, now performed over 130 patients now probably 150 patients using the Redaval handheld device. The mean age is 40, age range from 4 to 80. And we have used it on various diagnoses, including rod cone dystrophy, X-linked retinoschisis, cone rod dystrophy, Stargardt disease, macular pattern dystrophy, and drug toxicities and vitamin A deficiencies, as well as posterior uveitis, which I want to give you a couple of examples of. These are two patients. The first one, 68 years of age. You can see the birdshot lesions. Retina is slightly thinned. And we like to use Redaval, especially looking at the 30 Hertz flicker and the on and off response to track progression. She's been immunosuppressed, and hopefully with the successful immunosuppression and long-term treatment, that her peak amplitude here in the right eye is not going to decline any further, and that the B wave amplitude is not going to drop any further. So the on response is not going to be affected. This is in contrast to another patient who's similar age, 68, but has extensive chorioretinal atrophy in the setting of birdshot chorioretinopathy, where she has not been immunosuppressed. And you can see that there's extensive loss of inner retinal layer as well as outer retinal layers with preservation of foveal RPE. In contrast, her ERG, this is the light adapted ERG, shows severe reduction in the A and B wave, but there is still preservation of the 30 Hertz flicker. The on responses are gone. And this is what happens in the birdshot situation where, despite lack of any symptoms, disease has progressed over years. So the take-home message from talk is that a macular dystrophy cannot be diagnosed. You cannot diagnose a macular dystrophy just based on imaging alone. You have to demonstrate that the full field ERG is completely normal in the rod and cone pathway. So unless you have done a full field ERG, you can't call it a macular dystrophy. The second point is that a normal looking retina, even with ultra wide field imaging, with autofluorescence and OCT, it does not exclude a retinopathy. You may even have to perform light adapted testing using a handheld ERG, or even putting them through the full ICEF standard testing with the dark adapted testing if you suspect that there is underlying inherited retinal disease to exclude them. And finally, not all patients has to go through 3 hours of testing for the ERG test to be clinically useful. In some situations, particularly posterior uveitis, selected ERG testing may be useful. For example, in patients with birdshot chorioretinopathy, where you're immunosuppressing them for many years, you want to know whether that is useful or halting the disease process. You may just want to do the 30 Hertz flicker or the on and off responses. And I'd like to acknowledge funding bodies, especially our collaboration with the IRD registry, NHMRC Channel 7 Telethon, our registrar, Dr. Harry Honan, who has been doing most of our Redaval ERGs, and our electrophysiology service, Dr. Ina Chalva. Thank you.